cardiovascular diseases is a group of diseases, and it is the number one cause of death and disability on this planet. And an estimated 650 million people currently live with cardiovascular disease worldwide.
Wow.
So that's approximately 1 in 12 persons that has
Mhm.
cardiovascular disease.
Wow.
So if you look at US data, Black men are about 1.6 times more likely to die from heart disease and at young ages compared to white men.
Mhm.
Okay. They experience earlier onset of high blood pressure. They have higher rates of heart failure and stroke. They have greater mortality when they do have a heart condition, and they have more severe complications of these risk factors.
Well, welcome back to Real Health Black Men. Thank you for joining us. Thank you for your supporting us. I want to thank all who have just become our supporters and sending me notes and emails. I really appreciate that to let me know how to adjust the podcast to make sure that we're meeting your needs. Today, I'm in Barbados again, and I have the pleasure of meeting with Dr. Sayambo. Dr. Sayambo is a non-invasive cardiology specialist and a consultant for the Department of Cardiology Services at the Queen Elizabeth Hospital here in Barbados. She's also the founder of Heart Healthy Incorporated, a practice focused on prevention, diagnosis, and management of heart disease. And as you can tell, our topic today is going to be heart disease and heart health in men. So Dr. Sayambo, welcome to our podcast.
Thank you for having me. It's a pleasure to be here to talk about a topic that is near and dear to my heart as we talk about heart disease in men, but also this is also for women as caretakers. Also with heart disease, I have my heart disease pin on. So this topic is for everyone, really.
Yes, because
but with a focus on
a lot of time,
yes.
a lot of time, the caretakers are also a part of the story.
Definitely, the whole family.
So as we ground in, just give us a little bit about you, as much as you want to tell us about you and your upbringing, where you're from, or your practice, so that our audiences can know that you're not just a cardiologist, but you're a person just like them.
Yeah, well, so I like to consider myself, I am an American Niger Bayesian non-invasive cardiologist. So yes, people always ask me, where's your last name from? It is from Nigeria, which is where I spent most of my formative years, primary and secondary school. I was born in the U.S., which is where I went to college, medical school, did most of my medical training, and worked before moving to Barbados about 9 years ago, almost 9 years ago. So I went to medical school at University of Michigan, which is where I was born. And I had a friend there, his name was Kemi, who's from Barbados, and he would kind of rant and rave about rave about his little island of paradise. And so in the summer of my first year of medical school, I was interested in doing research and I wanted to go somewhere exotic. So I found something, a research program that was here in Barbados. It was a program sponsored by the National Science Foundation many years ago, and they sent us to the Chronic Disease Research Center here in Barbados, which was at the time under the leadership of Dr. Sir Henry Fraser. At the time, I had no idea what part of medicine I was going into. Cardiology was not on my radar. But interesting enough, our research was on acculturation and how Western values were beginning to impact the way of life in Barbados and leading to chronic diseases in Barbados. This was even before the fast food and chiffettes and things came around. And fast forward 25 years later, we know the impact it has and continues to have on the rise of heart disease around the world, acculturation and Western way of living. So as I mentioned, cardiology was not on my radar, but I did my cardiology rotations and I was hooked. I love the heart. I was fascinated by the heart. And I do like working with my hands, but I know I didn't want to be a surgeon. So cardiology sort of gave me a perfect balance of doing procedures, patient management, continuity of care. And, that's what I decided to go into it. So I had to go into internal medicine first, which I did at Cornell University, New York Presbyterian Hospital in New York. And I did my fellowship training in cardiology in Georgetown University, Washington Hospital Center in DC. During my training, I did get a chance to come back to Barbados to do an elective. I also went to Nigeria, so that gave me a bit of an exposure into the healthcare system in both places. And then after training, I went on to practice in New Jersey before I relocated to Barbados in 2017, generally for a change of pace. And because I kind of knew the environment, it kind of was a balance between the U.S. and Nigeria.
Barbados grew on you.
It grew on me. It definitely grew on me.
It has
And it
a habit of doing that.
really reminded me of growing up in Nigeria.
So you said you were a non-invasive cardiologist. You're not a surgeon. And to many of our listeners, that may be a surprise. So could you explain the difference between what you do and what other cardiologists do?
So there's cardiovascular surgeon. So those are actually, so people always ask me, oh, do you operate?
Right.
Surgeries, so that's a whole different field. So as I said, I went into internal medicine.
Okay.
So you learn medicine, and cardiology is one of the subspecialties of internal medicine.
Okay.
And then there's a field of surgery, and cardiovascular surgery is a field of surgery.
Okay.
Under cardiology, there are many subspecialties. So you have invasive and non-invasive. So invasive will be the cardiologists that deal with procedures. So if you have a blockage in your artery, they would do the angiogram. Or if you need a pacemaker or have a problem with the electricity in your heart, they would go in, and when we say invasive, meaning they're cutting the skin,
Right.
it's not open heart surgery, but they're breaking the skin to do procedures on your heart. And then there are also structural cardiologists that do things also outside of putting stents, putting in valves percutaneously and repairing things percutaneously without having to cut open your heart. So that's the invasive side of cardiology. The non-invasive side is where I'm at, which is more imaging and patient management. So all cardiologists, for the most part, all manage patients regardless. We all do a bit of imaging, but we focus more on the imaging side of things and the patient management. So the testing, so the stress testing, the echocardiograms, the ECGs, the Holters, using all of those things to make a diagnosis without having to go in and cut open the skin. We do some minor procedures as non-invasive cardiologists, such as, transesophageal echocardiograms, where we go in with a camera to look into your heart. And there are some non-invasive cardiologists who do some invasive, but not interventions. So they go in and do the caths, but they don't necessarily go in and put in stents.
Okay.
So, and then you have the electrophysiologists who deal with more the electricity. So many different parts.
Right.
But so I work in non-invasive, which means I don't break open the skin for anything I do related to the heart.
So most people think of the cardiologist as a cardiovascular surgeon.
Yes.
But it's a broader field.
Yes, it's different. And their training is much different because they learn general surgery and then they branch into cardiologists, whereas we learn internal medicine and branch into cardiology. But it is different depending on what country you go to. So in the US and I think Barbados and the Caribbean, that's generally how it's done. Yeah.
Okay. So what does your Heart Healthy Institute do here?
Healthy Heart Imaging, Healthy Heart Inc. and imaging. So I love the balance of hospital work and private practice, continuity of care, prevention, managing people with heart condition, and helping them live healthy lives despite having a heart condition, or preventing a heart conditions by being proactive in terms of what they're doing. So most patients are referred to me from primary care doctors, or if they've been hospitalized, either because they're at risk of a heart condition or because they have symptoms that might be suggestive of a heart condition, or they are at risk, meaning family history or something else is going on. So we see patients here. We do cardiac testing, ECGs, Holters, stress tests, echocardiograms, and we refer patients out for any further testing that they may need that's not done within our office here.
So just from a layman's terms, it seems to me like a person may have a cardiology issue or not, but you're testing to see if they do. And it doesn't mean that eventually they may not have to see a cardiovascular surgeon, but your work seems to me to be before that and looking at, are you healthy or not? If you're having a murmur or not, the stress test, that kind of stuff. I'm thinking of it along a line. The end of the line may be the
surgeon,
the invasion,
right.
But there's a whole bunch of things that can be done between I'm not feeling good to I need a cardiovascular surgeon.
A lot of the time, our patients don't end up with a cardiovascular surgeon. We don't want you to end up with a cardiovascular surgeon.
Right.
Unfortunately, and as I said, cardiology, the field of cardiology is changing. We're able to do a lot more, especially in bigger countries. We're able to do a lot more that does not involve you going to a surgeon. So less invasive procedures that don't require cracking open the chest. But obviously that is, and seeing a surgeon is not the end of it, because the surgeon does their surgery and you still come back to us, the cardiologists. So we manage patients that have already seen the surgeon as well. They come back to us for continuity of care and to make sure that whatever condition we fixed, we can continue to manage it.
Okay.
Because of course things can progress and get worse. and you need maintenance to make sure that that doesn't happen. So we like to avoid the surgeons, but we do work hand in hand with the surgeons at the hospital. We have conferences where we discuss every patient we send to surgery. We have a cardiac team
Hmm.
where we meet and discuss what the imaging, what the testing, what the symptoms. We talk about the patient, and then we send them to the surgeon. So we all work very closely together, but we want to avoid them seeing a surgeon if possible.
Can you define what cardiovascular health is and then some of the specific areas that it may encompass?
Cardiovascular health refers to the health of the heart, which is cardio, and vascular, which are the vessels of the body, right? And I do like to differentiate it from cardiovascular diseases, which are diseases of the heart and the blood vessels,
Okay.
right? Cardiovascular diseases is a group of diseases, and it is the number one cause of death and disability on this planet. Planet meaning including Barbados. And an estimated 650 million people currently live with cardiovascular disease worldwide.
Wow.
So that's approximately 1 in 12 persons that has
Mhm.
cardiovascular disease.
Wow.
When we think of cardiovascular diseases, we're talking about all the diseases that affect the heart and the blood vessels. So just to kind of go through them with you. And I think an easy way, well, I'll come back to the analogy, but so we talk about the diseases that affect the arteries. Okay, so arteries that supply blood flow to the heart. If there are blockages there, that can cause heart attacks, angina, ischemic heart disease, coronary artery disease. We also have diseases that affect the arteries going to the brain, which can lead to a number one cause of strokes. You have diseases that can affect the arteries of the leg, causing claudication, or what we call peripheral vascular disease. And then you have all the diseases of the arteries, such as aortic aneurysms. You can have blood clots to the arteries that go to the lung, pulmonary embolus. And then we talk about the valves in the heart, which can also malfunction and can have valvular heart disease.
Hmm.
And then there's some rheumatic, which is diseases from infections in the past, strep, and other congenital diseases. We also have arrhythmias, which are diseases that affect the electricity of the heart. So these are all the spectrum of cardiovascular disease. And one important one I didn't say was diseases of the pump of the heart. That's heart failure. So all of these things come together and form the spectrum of cardiovascular diseases. So I like to kind of think about it as your home. You know, you have plumbing, you got to make sure it's working. You have electricity, you got to make sure it's working. The pump itself, the valves, which would be the doors. So you want everything to be in good working order in order to have good cardiovascular health. And one thing to keep in mind is that, you know, cardiovascular health goes beyond the absence of disease. Really is just about focusing on how efficiently your heart and your blood vessels can help pump oxygen and nutrients throughout your body to make you live a long, healthy life.
So, what are some of the various aspects of cardiovascular health that we as people need to be aware of? This show is about Black men. Everybody has a heart,
Right,
so
right.
I'm sure there's not anything unique to Black men, but we can get later into how it
Specifics, yeah.
differentiates into Black men.
Yeah.
So, what are some of the factors and some of the things that we
Right.
need to be aware of?
So I think the best way to think about this is using the framework that the ACC, the American College of Cardiology, has sort of put out. It went from Life's Simple 7 to now Life's Crucial 9, sort of the 9 things that we can regulate or control in order to have a healthy heart. On that note, all of these things obviously contribute to cardiovascular disease. So if we can deal with them, then we can reduce our risk of cardiovascular disease. So I like to break them into 2 groups. So one is healthy factors and the other is lifestyle behaviors.
Yeah.
So health factors, lifestyle behaviors. So some of those health factors, again, which most of us know. So blood pressure, blood sugar, blood cholesterol, body weight, and psychological health. All right. So these are factors that affect your cardiovascular health. And obviously the diseases that can come out of those, if those factors are not controlled, include hypertension, high blood pressure, high cholesterol or dyslipidemia, diabetes from blood sugar, and obesity and metabolic syndrome from your weight. Lifestyle behaviors that can affect these things and also affect our overall health, not just with heart disease, but all disease processes, are the lifestyle behaviors that can contribute to these things, but that we can also change, which will include, of course, diet, physical activity, let's not forget sleep, avoiding tobacco or smoking, and then stress, which contributes to the psychological health. So I have stress or psychological health under both groups,
Yeah.
right?
And
Health factors and lifestyle behaviors, because
Right.
stress is something that can be a medical diagnosis, anxiety, depression, other things that can affect your psychological health. but there are also things that in our behavior that contributes to our psychological health, which can include stress and other things if not managed correctly
Yeah, well,
or
that's
adequately.
very interesting because I've been doing a few episodes lately on mental and emotional health,
Yeah,
and many doctors that I've talked to, or even practitioners, a lot of times we don't get into the emotional and psychological health, but you went right into it. So there must be something there that your cardiologists see that our mental and emotional health has a direct impact on how our heart functions.
100%. And while it is a big field,
Right,
not
very
my
big field.
necessarily my area,
Right, yeah.
but we see it in everything. And people manage their conditions, in terms of taking care of themselves and being able to do things they need to do for their heart health, anxiety playing a role, depression playing a role. And we do know that, when people do have an event, a heart attack, it's not always the 90% clogged artery that causes that. It's the vulnerable plaque in a 50% clogged artery. And we don't know what it is that causes that artery to suddenly rupture and cause a heart attack. And I think, stress and other things probably play a role with that. And there are some conditions that are directly linked to stress. There's some heart failure or heart pump condition, heart attack conditions that are directly related to overwhelming stress. So we see that obviously stress affects all of the factors we talked about: overeating and developing obesity and metabolic syndrome, eating the wrong things, high cholesterol, salts, and developing high blood pressure. So it affects everything. And again, all of these then contribute. So we see it a lot in cardiology and even treatment and management, in terms of how people approach doctors and how people approach taking care of themselves. If you're not mentally or psychologically well positioned, then it's going to be very difficult to manage a condition that you're diagnosed with. We're able to treat you and get you to lead a good, healthy life. But if you can't manage those psychological factors, then of course it makes it very difficult and you get sicker and sicker and develop more complications.
So you may be doing all the physical things that you as specialists can help with and other medical professionals, but then you go home to a situation that everything you might have just done for the last 2 hours
Right.
begins to unravel because the home situation
Yeah.
or the geography where a person lives
Yeah.
automatically then just starts. And sometimes do you find that people are not even aware that these things are causing stress in their lives?
Yeah, no. Yeah, absolutely. People don't realize how much of a role it plays, and
Right.
they ignore their health. One, because they're under a lot of stress, or they don't ignore their health. They're doing a lot. And I think there was a concept I was going to bring when we got to speaking about the genetic role that it plays. But there's something that I came across, the John Henryism effect. I don't know if you know what that is, but that's
No.
where we talk about the physiologic toll of chronic repeated exposure to systemic stressors can interact with genetic factors to sort of accelerate cardiovascular aging and high
Mhm.
blood pressure. So that's where people are doing a lot. I think John Henry was a man that he came out of slavery. He owned all this wealth. And at the age of 50, he died of heart disease because of achieving so much and just pushing, pushing, pushing,
Mhm.
pushing, and
Yeah.
not realizing that he was under a lot of stress trying to overcome. But then at the end of the day, he died at a young age because he was not prioritizing his health and just not even realizing probably that he was under a lot of stress.
Wow,
Yeah.
that's interesting
Yeah.
because as you're saying that, my mind just started to turn. This is not even on our plan, but I'm on a committee, a patient advisory committee back home, and one of the researchers that the patient committee that I'm on is called the GEMS Advisory Group, and is looking at the germline, the environmental, the social, political, and
Mm,
cultural aspects of lethal prostate cancer,
mm,
right? You can probably apply it to heart disease
right.
too. And what it came out of is that they found that there are other things that they don't measure in the doctor's office
Oh, yeah.
that has an effect on a person's lifestyle and
All
their
right.
health. And where you live could be where
All
it is.
right.
Your germline, your genetics, but the environmental, social, and
All right.
political things that people are into. One of my therapists that I interviewed said he talks to people who not even have realized that we have undergone a trauma and
Right.
we're still moving forward. We just automatically adjust to that and keep moving
Yeah,
forward,
exactly.
not realizing that that's putting a stress on our
All
body.
right.
And as you're talking, I'm seeing how that also relates to heart disease.
Yeah,
It
yeah,
could be.
absolutely.
You could walk into
Absolutely.
another person I was talking to was saying that some of the people they've been trying to help, they found that if they don't look at where they live, most of the things that they're trying to do don't work because a lot of their clients are going back into environments that are contradictory to what
Right.
they're trying to accomplish when they're there.
Right. It's a big field and
Yeah.
it's a lot that needs to be addressed from a global and a public health standpoint. As much as we try to address it in the office, we don't have all the answers and we don't have all the metrics to use at this point. Yeah.
Yeah. So, what is just to finish up this section here, what does a patient need to be aware of in terms of what are their numbers or their things that they should be tracking? You mentioned some of it, but when we say like blood pressure or cholesterol or that kind of stuff, can you put some numbers to it that people can see it? Because some people I talk to say, I get this results back from my doctor, and there's a whole bunch of numbers, and I don't have a clue what they mean. And some people call their doctor and say that, but a lot of guys say, "Oh, I just filed that away because I don't understand what it meant."
Yeah, and that's why we're talking about, a lot of guys, especially the men, right? So
Yeah,
I think even before we get into the numbers, I
yeah,
wanted to just sort of put in perspective exactly. We talked about how many people have heart disease, but let's even just relate that to Barbados and Black men and women in
okay,
general. So if you look at US data, Black men are about 1.6 times more likely to die from heart disease and at young ages compared to white men. Okay. They experience earlier onset of high blood pressure, which you brought up. They have higher rates of heart failure and stroke. They have greater mortality when they do have a heart condition, and they have more severe complications of these risk factors, dialysis, and other conditions. And we have to keep in mind that race itself is not the disease. As we said, the drivers are a mixture of biology, the environment, access to care, chronic stress, our nutrition, our sleep habits, and most important, economic inequality, right? The system and a mistrust in the system, especially for Black men. So these disparities are really driven by these factors and not necessarily by genetics, even those genetics do play a role. And when you look at Black women, they tend to experience a higher burden of specific risks like stroke and hypertension compared to men, or compared to, I shouldn't say men, compared to other ethnic groups. However, Black men are more likely to have a higher mortality rate. And for women, it's at a much older rate. So when you look in Barbados, the Barbados National Registry for Chronic Diseases actually tracks and records data on cancer, stroke, and acute heart attacks here in Barbados in order to help improve, health programs and to monitor disease. And in 2022, that's the most recent data we have of everything. 556 Barbadians had a heart attack. 765 had a stroke. That's about 10 heart attacks a week, about 14 strokes a week on average. So this may not seem like a lot, but given our small population,
well, yeah,
it is.
on our island, it's a lot.
It is a lot. And if you look at, so easy way to look at it is that for every 100,000 men in the population, about 146 had a heart attack and 98 died of a heart attack.
Wow.
When you look at women, 89 out of 100,000 had a heart attack and 64 died of a heart attack. So, and this is just in 2022. So as you can see, men make up slightly more than half of those cases totally. And most of the men, in the men, the cases occurred mainly in the 55 to 74 age group, whereas in women, it was above the age of 85. So younger men are developing these conditions. So these figures from 2022 are one of the highest figures they had seen in the 14 years they've been following these numbers. I don't want to assume, but I'm the sense I get is that those numbers are going up, despite what we're trying to do. If you look in Nigeria and the rest of Africa, cardiovascular disease is now accounting for 1 in 3 NCDs, almost getting to the point of infectious diseases, which are the number one causes of death in Africa. And of course, these rising cases are being driven by lots of things: rapid urbanization, sedentary lifestyles, everyone has a car now. So all of this is triggering an increase in high blood pressure, diabetes, obesity, and causing more cardiovascular disease. And hypertension is one of the biggest drivers in Africa. And it's not so much that these are just statistics, right? If you don't die from your cardiovascular disease, you're left with a disability. So which impacts your ability to work. It affects your independence. It affects your family,
Your
workplace, income, everything.
Yeah.
And then that even adds more stress to everything. So one of the things is we have to ask is, why are these numbers going up, right? And some of that just has to do with some of the stubborn rise in these risk factors, risk factors we discussed, and delays in not getting treated, not recognizing these risk factors, not having warning signs, presenting too late. And when you do get to the hospital, sometimes you don't get the care that you need, either because of lack of resources, which is an issue here in Barbados, and also even in the U.S., depending on places you live.
Depending
You
where
don't
you
get
are,
easy
yeah.
access to, as we talk, it depends on where you live as well. There's also inequalities in terms of treatment, and they've seen that as well. So all of these things are why heart disease is such a big deal. And that brings me to your question about high blood pressure. So I think hypertension is one of our biggest issues, especially in Black men. I think it's one of the single most important thing if we're going to discuss cardiovascular disease and how people can change things.
You know, it's interesting, right? Because as you're thinking there, I'm thinking a lot of people have this idea that you live on an island and everything is chill.
Right.
And nobody,
Everything
you know,
is
like you
eerie,
see on
right?
TV
No
and all.
stress.
Everybody's on
Paradise living.
stress, paradise
Oh,
living.
no.
There's lots of fruits. Everybody's on the beach. But here we're talking about high rates of stress and cardiovascular disease and getting into hypertension.
Fine, because even when I moved to Barbados, people always thought like, "Oh, you're just living in paradise." I'm like,
Right.
"No, I'm working, I'm hustling, like just like you."
Yeah.
It's just that yes, I get to see the beach more
Yes.
regularly, and maybe reduces my stress level. And if I want to go, I don't have to drive 100 miles. I could just
Yeah.
walk to the beach. So yes, but yes, I know the feeling. But I mean, I think
let's get back to the risk factors there. We're getting
Right.
back into hypertension as one of the central
right.
issues when it comes to cardiovascular health.
Right. And, something you brought about is even in Barbados, like you said, you looking at the island and everything, and why is it that we still have such high rates of hypertension? And, there have been we do know that there's a genetic factor, and we also know that there are environmental factors, right? So genetically, studies have shown that people of African American descent do have specific genes that help regulate salt and water that are abnormal. And so as a result, we're more sensitive to dietary sodium and increased risk of high blood pressure. And as we know, as we mentioned, the genetics itself interplay with environmental factors that then lead to us developing high blood pressure. So one of the things, again, diet. So depending on where you are, depending on your socioeconomic status, we tend to eat a diet that is low in potassium, high in sodium. So when you already have a genetic predisposition to it and you have a diet that is not a balanced diet, either because you're not able to afford a healthy diet, or because you don't have the knowledge to know what is healthy, or because you're young and you think, oh, I can eat anything I want. You add that to the genetics, and then we start to see that's why we see so much high blood pressure in Africa, in the Caribbean, in the United States. And again, high blood pressure is one thing that we know puts you at risk of developing. 90% of people that have strokes and heart attacks have high blood pressure, especially in Black people.
Okay.
So it's very important that, if we're looking at something, again, cardiovascular disease is a huge topic and we can talk about so many things. But I think when it comes to men, we really need to look at high blood pressure as something that we can manage, is treatable, and we need to pay attention to if we're starting somewhere.
And it's preventable.
And it is preventable.
Yeah.
Right.
So that's interesting. And we can get into the misleading stuff about I'm feeling okay. But just this morning, I was with some people, and one of the guys was there, and he was saying a lot of times guys don't want to go to the doctor because they don't want to hear the bad news of I may have this and I may have that. And I said to him, knowledge is the key. Not knowing what you have, you can't do anything about it.
Right.
So the doctor is not giving you bad news. The doctor is giving you information that
To
you
help
need to
you.
be able to assimilate to make a decision.
Yeah.
If you don't go, you don't know.
Yeah. Yeah.
I mean, literally 2 hours before I came here, I had this discussion
Yeah.
with a friend here on the island.
But I think people think ignorance is bliss, and and they're not thinking through, and then they end up in the hospital in a very bad state. As you said, there are lots of myths that surround people going to the doctor, and there is this fear, especially among Black men, about going to the doctor. People think that if I go to the doctor, they're going to put me on medications. They don't want to take the medications. It's funny. I just this past week, in our line of work, we see patients in the hospital, and I was rounding. I mean, first, I can't tell you how many times when I am rounding with the junior doctors, and we see a lot of heart failure patients, and they come in and they present the patient and say, patient has no past medical history. Meanwhile, their blood pressures are through the roof. And when you actually push a little further and ask them a question, when was the last time you saw a doctor? They haven't seen a doctor in years.
Yeah.
So they don't have any past medical history because they haven't seen a doctor in years.
They haven't created the file.
Some of them since they last saw their pediatrician, or they saw a doctor and they were told they had high blood pressure and were told, okay, you need medications, and they never went back.
And they never went back. Yeah.
Yeah. Or they go back and they just don't want to take the medications for many reasons. There was another issue is just a fear of doctors. There was another patient, that funny guy I saw in the hospital last week, and, he presented because he was filled with fluid. His legs were swollen like 3 times the amount. He only presented to his GP because he had scrotal swelling. It had progressed up to the point that it was affecting his scrotum. And I asked him, when's the last time he saw a doctor? And he couldn't tell me. And so I asked him, I said, as I know I was preparing for this podcast, why is it that men don't like to see the doctor? And he said, well, I'm paraphrasing, of course, because, his language was a bit different. But I guess he was talking to a friend, and a friend was describing how he went to go see the doctor. And he said, don't nobody want, no doctor putting a finger up in my, behind and making me pregnant. So there's this misconception. Obviously, he doesn't mean making pregnant.
Right.
But he's talking about rectal exams.
Yeah, he's talking about the discomfort that,
Right. And
look down on.
So there's this fear that you're going to go to a doctor, they're going to do something without understanding that these things may serve your life. We want you to live a healthy life. We want you to live a productive life. And, it's about having a conversation, because there are many ways to skin a cat. And you have to see the doctor first, have the knowledge of what is going on, or even things to prevent you from developing a disease process so that you can, get the best out of it.
And it's not your doctor's fault that doctor's just presenting you the information. The doctors didn't cause you to have hypertension or cause you to have prediabetes. The doctor's just telling you what he's seeing. And I don't know why there is that mental block for so many of my brothers about getting that information and using it to make wise decisions. You don't know. I interviewed another Barbadian a while back, and unfortunately he passed away this spring from another disease. But he said the fellas, right? That's how we say it in Barbados. He said the fellas always saying, you ask them, how you doing? I all right. I all right. He said everybody all right until they bend over in pain, and then they say, I think you need to call the doctor for me. Right? And what he was saying was that, fellas, don't wait till somebody got to call the doctor for you. You need to go to the doctor while you're still all right.
Right.
Because all right is okay, but that doesn't mean you don't need to see the doctor. But we were just laughing the way he was putting it. He said, everybody all right.
Yeah, no symptoms. They think no symptoms. So lots of myths. No symptoms means no problem.
Right.
I'm okay. I'm young. I'm safe. Right.
Yeah.
Right. Some people think, well, I work out, so of course I can't have heart disease. I mean, you had someone on your podcast who, gratefully, and I thank him for sharing his story. He was an avid fitness enthusiast, and he had heart disease, which was surprising to him.
Serious.
So. Other myths is that blood pressure medications cause erectile dysfunction. You also had someone on your podcast that it's not the blood pressure medicines. I mean, there are a few, okay, but most of it is a disease process. So that's another myth that people think. And some people are like, well, it's inevitable. I'm going to get high blood pressure. I'm going to get heart disease. So you know what? I'm just going to avoid the doctor and do nothing about it.
Yeah.
I had a close friend who that was a situation. He had a family history of heart disease, and I think he just felt it was inevitable that was going to be him. And he just did not want to get help. And unfortunately, he passed away.
Yeah.
And by the time he realized he had symptoms, it was too late, despite being counseled on getting checked, on, trying to get the cholesterol down and get things down. So there's this fear, and I think there's also this sort of, it's inevitable and there's nothing that can be done about it. There's a lot that can be done about it. And you can live a long, healthy life, even if you're diagnosed, or even to prevent being diagnosed. If you know you have a family history and you're proactive about getting your numbers checked. I have a family history of diabetes, so I have to be careful, right? I know there are things I should be doing so that I don't develop that, so that I don't develop, complications of that down the road.
Yeah, there's so many things you can do with early detection and prevention that prevents you from getting it. Let's talk a little bit about the cultural factors. We have dietary factors. So Food is really important in cultures, all
Mhm.
cultures, and you know this, and I know it from our cultures. A lot of us come back to Barbados and we want to eat Bajan food and we want to do all this
Mhm.
stuff and we have our preferences. And I also remember you talking about when you were in medical school, coming and studying
Yeah,
how the
right.
diet was changing due to influences from America and Europe,
Yeah.
right, in the diet. So let's talk about dietary factors a little bit from a cultural perspective, because it doesn't mean that it's bad, but what do we need to be aware of about how our cultural preferences or cultural lifestyles may affect us health wise?
I think, as you said, it's a good question. Food is very important, and not just food, but good food.
Good,
People want to
yes,
eat good
good
food.
food.
Good food can be expensive. Our stressful lives make it hard for us to make good foods at home.
Hmm.
So when you add that into the equation, what happens is people are eating out a lot. All right. And back then, so one of the things we looked at, we went into the polyclinics and sort of had focus groups and discussed with, people about their dietary modifications and what they were doing. And you could tell that people were moving away from home cooked meals where you use ground provisions and healthy, your proteins and your plant-based diet and healthy things to cook, chicken, to moving into now convenience foods, right?
Hmm.
You don't have enough time to cook. So you're eating fast food that's loaded with salt, loaded with grease, loaded with calories. And, so it really plays a role in terms of why we're seeing this rise in NCDs around the world.
And we're more sedentary too.
And then you add the sedentary aspect of it. You go to a drive-through, you sit in your car and you can't not even walking to get your food. I mean, don't get me wrong, I go to the
We
drive-through
all do,
sometimes.
but you
But,
think about it, yeah. The difference
but
is like 20 feet,
all
but we
right.
don't get out of the car,
All
yeah.
right. And even when we look at our culture and saying that, oh, we want to eat, people want to eat well, eating out a lot versus, as I said, the old way of cooking. You have some of the octogenarians that, work the fields and they also ate what they worked and have lived long, healthy lives without comorbidities.
Mhm.
But now we're seeing 30-year-olds developing diabetes and high blood pressure. And a lot of that, again, has to do with, I think, that we are the stress and not going back to how we used to eat back then. And then, of course, things that processed food, a lot of, even if you're not eating out, it's easier to buy stuff off the shelf and throw things together. I mean, even I do it, right?
Mhm.
Because you've had a long day at work and you come home and you don't have time to, start soaking or craving something in the morning, finishing up it at night.
Yeah,
So so even within your house, even if you don't eat out a lot, you're still buying a lot of processed foods. And we know that these processed foods, sugar sweetened beverages, other things that we're using, alcohol being one as well. Easy access to alcohol, again, to combat stress. And just because people feel like it doesn't make a difference, it's okay to drink. All these things affect our health. These are all parts of dietary things that we could change that could improve our health.
yeah, and sometimes, I try to be particular about saying when we talk about diet, it doesn't always saying that we can talk about the things that negatively affect our
Hmm.
health, but there's also things in our diet that positively affect our
Right.
health that we can
Absolutely.
increase, more turmeric and more natural foods into our diet. So diet doesn't always have to be negative. It
Right.
can be asking the question, what can I do within my lifestyle and my environment
Right.
to make my health even better.
Right.
And so, yes, I don't have time to cook like I did, but when I eat, what can I be more
What can I put
particular
in there
about?
that's going to be more, yeah, that's going to be
Be
more beneficial
more beneficial to me
versus not. And there are
rather than.
lots of tricks and things there that people can get information about. If you're having difficulties, you can speak to your doctor. There are lots of nutritionists. And I don't want to say dietitian. They don't like to be called that, but nutritionists who can guide you to
I
the right
do.
things to eat. Because a lot of time people think, oh, I'm doing nothing wrong. My blood sugar is spiking. My
Mm,
blood pressure is high. I'm doing nothing wrong, right?
right,
But they don't understand that nothing wrong might be exactly what they're doing that's
right.
affecting.
Because it's so natural.
Right. So
Yeah,
even for people
knowing that.
sometimes with diabetes, they say, well, I can't get my sugar under control. I'm eating lots of fruits and vegetables, but
Hmm.
some of the fruits, have a lot of sugar.
Sugar in
So
it.
you have to eat them. You have to know which ones and you have to eat them in moderation to make sure they're not spiking your blood sugar.
Yeah, and I think this is a really important topic too, for especially for men, because a lot of times when you start talking about dietary, guys are like, "Well, I don't want to go on a diet. I want to eat what I want to eat, and I want to do it." But dietary doesn't always mean you go on a diet.
No, it's
It means
not.
sometimes it means you just do a few little changes here and there that can have a big
Small
effect,
steps.
right? Because that's one of the cultural things. Women go on diet, men don't,
Yeah.
you
But
know.
even women, for diets, again, one thing people, as you said, it's not about, I always look at it a lifestyle change.
Right,
It's not a
yeah.
diet, it's a lifestyle
It's a
change.
lifestyle
You're eating
change.
better, you're eating healthier, right? So
Right.
more fruits and vegetables, smaller portion sizes as much as you can, and not making drastic changes. Yeah, you want to go to that wedding and fit in that dress. You might go on a diet and make a drastic change for that reason. But
Right.
really, it's not sustainable if it's not a lifestyle
Right.
change that you're
Right.
making. And little small steps can make a big
It
difference,
can be very incremental. You don't
very
have to do some of
incremental.
this stuff you see on TV, cut out everything and don't
Yeah.
do that. And
Yeah.
sometimes that's in people's head, right?
Right.
Like you said earlier about going to the doctor, right? It's in your
Right.
head. The
Right.
same thing with food, it's in your head. Well, if you start talking to me about nutrition, that means that you want me to cut out everything. My food's
Yeah.
not gonna have any taste, my drink's not gonna have any taste, everything's gonna be bland. I don't want to talk about that.
And I
And
think
that's not what we mean most of the time.
it's not, but I do think that there are some physicians and doctors out there. And I remember I was talking to a friend of mine who got a scare. And, we have to understand we don't want to have the patient not come back and see us because we've now told them, don't eat anything, don't drink anything, right?
Right.
You have to create that patient trust. So patients have gone the other extreme and then got sick because, and that was the case. The doctor, I think he was found to be pre-diabetic and he cut everything out. And he was so miserable, he was miserable. He was weak. He was tired because the doctor said, no this, no that, no this, no that. And that's not, it's not easy to do. So
And
we
it's
have
very
to be
abrupt too.
mindful, very abrupt. We
Right.
have to be mindful of how we educate patients. And yes, we don't have all the answers. And that's why I tell a lot of people, well, you're better off seeing a nutritionist because it does take a lot of time to sit and discuss all the different things and going through your food journal and all of that. So we have to be mindful of that. And patients also have to be mindful of that. That's small steps and not drastic, big changes. Yeah.
So, doctor, what advice do you have for men who avoid regular medical checkups?
Well, first and foremost, you're not going to know until you're checked out. All right. We always, one of the campaigns around the world and even here in Barbados, Heart and Stroke Foundation, is to know your numbers. You had asked about blood pressure. So if you don't see your doctor, how are you going to know where you lie, right? Knowing what your blood pressure is and what it should be. Normal blood pressure is less than 120/80. That's normal blood pressure. People think only the diastolic being high is the issue, or that 130, 140 is fine. Sometimes I ask people, what's your blood pressure? Oh, my blood pressure is fine. And I said, well, what's the number? 140s, 150s. So you need education in terms of seeing the doctor, let them pointing out that your pressure is high and ways you can try to bring that down. Diet, exercise, they can look lifestyle modifications and they follow you over time so that as that blood pressure starts to go up past a range where maybe diet and exercise is not good enough, they can start to have a conversation about medications and what medications are going to be best. If you're calm and your pressure is through the roof, you may have to be started on medications right away because you are at risk of having a stroke or heart attack short term as opposed to, long term risk of those complications or dialysis or things like that. So you're not going to know your numbers. You're not going to know your cholesterol unless your doctor checks the blood test.
Yeah.
You're not going to know your PSA unless the doctor checks the blood test.
Sure.
You're not going to know if you have diabetes, a lot of these things. And that's one of the reasons hypertension is called the silent killer because people don't feel it. By the time you feel it, it's already too late. It's already causing damage slowly in different parts of your body. Same thing with blood sugar. By the time you feel it, sometimes you already have some damage already in your body. So in order to know your numbers and to lead a healthy, productive life, you have to see your doctor. And there are guidelines and recommendations for how often you see the doctor after, you leave the pediatrician. It might be every, 2 to 3 years. 3 to 5 years, depending on where you are in your age. But once you get to a certain age, you really need an annual physical. Now, for young adults, it's 2 to 3 years. And then once you get past a certain age, you should see a doctor annually. If you're on medications, you should be seeing the doctor every 3 to 6 months so that they can continue to fill the medications and observe your treatment to whatever medications you're on, whether it's for the blood pressure, whether it's for the cholesterol. So it's not a one fix. It's monitoring and managing these conditions by adjusting things.
And it may need to be adjusted, yeah.
Yeah, and there has to be. Your body's changing. You're getting older, and different things change in your body. You go through a stressful period, and your pressure goes through the roof. So things are constantly changing, and you need to be guided by that doctor. So find a doctor that a GP. You always start with a general doctor. I have some people that come directly to me, but I always tell people always have a general practitioner that you can grow with, because then they have records when your kidney function changes, when the PSA changes, when the blood pressure changes. They keep track of your records, and you start to develop an honest conversation. You can have shared interactions with them in terms of how best to take care of yourself.
Yeah.
So that's what I would advise, that at least see a doctor, incorporate. Now, we have a public health system. All right. There's no reason. There's complaints about long wait times in the polyclinics, but every single person in Barbados is able to see a doctor for free. The hospital is supposed to be for acute care. And when we have a lot of people coming in because they haven't been managing themselves adequately, the hospital becomes overwhelmed. So it is there for acute care, but people need to take advantage of the private doctors, the private GPs, and the polyclinics in order to get themselves checked
Yeah.
at least once a year, even if they're healthy.
Yeah. And that's a Caribbean context, and those are available all across the island, all across the country. But even for people in the United States and other places, a lot of people have health insurance,
Yeah.
and certain annual physical and certain tests are free
Yeah.
within the health insurance
Yeah.
policy, and we still don't take advantage of it. So yeah, we have the system here. We need to take advantage of it. But those of us who are in other countries, there may be other things you can do for your annual physical that don't cost you anything and don't send your price up. All it costs you is a visit to the doctor to get it done.
And it's much cheaper than on the back end when you do get a medical condition that could have been avoided or managed correctly, if you're waiting because you think you can't get that health care or that preventative care that you need.
Yeah, and sometimes you can just let the doctor know, that something is going on. In the U.S. or where we live, we have something called My Charts.
Yeah.
And it's this sophisticated thing, all
Yeah.
your testing and everything in there. But one of the beautiful things in it is that you can send a message to your doctor. Because a lot of times people call the doctor and they say, I'm ready for the doctor to call back. And doctors are really busy. But I love that because you can send them a message and you can get an answer back. And sometimes it's not the doctor, maybe the nurse practitioner or whatever, but they run it by the doctor for you during one of their breaks, and then they get you an answer back to your question.
Right.
I mean, that is like beautiful.
And everyone is working together. Again, electronic medical records have really been a game changer. So people are able to have more interaction. They're able to have access to their numbers, their lab values, their blood pressure, all of those things that you need to know.
Mhm.
I mean, it's something that we don't quite have yet here in the public setting. In the polyclinics, there's a bit of that, but they're working on it, and that's something that is coming in terms of an electronic medical record and giving people access to their information, so that they know how best to do with it. I mean, of course, you don't want to just have the information blindly. You
Right,
have
yeah,
to be
the
guided by the
contextual, like,
information,
yeah.
because otherwise it can cause even more stress, not knowing what those numbers may mean.
We can talk about that. I won't get into that. But let's talk a little bit about your preventative care and screenings.
Right.
Then we can wrap it up. So we talked about know your blood pressure, know your cholesterol, diabetes screening, weight circumference awareness, family history. Let's talk a little bit about the genetic. But I think we touched on it a little bit, that sometimes genetics can play a part in our cardiovascular health, but that doesn't necessarily mean that it's hopeless.
No, not at all. The whole goal is whether you have heart disease or you're preventing heart disease, it is treatable.
Mm-hmm.
And you can live a full life with that. But it's important to know what your risks are. Family history is very important from that standpoint. So one thing I do know, I mean, a lot of the older people, the older folks, they didn't like to bother their children. They didn't like to tell them what was going on.
Mhm.
They for fear of putting that weight on them or scaring them. But it's important to know. Like, one of the questions I always ask when I see patients is family history of sudden cardiac death, and what was the cause? Do they know what happened?
Mm.
Or they might say, yeah, my mom has heart disease, but they're not really sure exactly what it is. Well, you have to know these things. Just because you know it does not mean you are going to have that disease
Right.
process. But it helps us know what to screen for. It's kind of like with breast cancer. If you know you have a family history of breast cancer, you should get screening early at an earlier age than someone who may not have a family history. So it's not just cancers, but even for heart disease, what did the parents or the grandparents die of and what age did they die from? So that, as I said, not every genetic condition is passed down. Very small amount is passed down, but it's important that you know so that you can adjust your lifestyle and know when to seek a doctor, especially if you're having symptoms that you're not quite sure about, so you can address those things and prevent a complication.
So what are some of those then?
Heart disease or cardiovascular disease has a wide spectrum depending on what you're looking at. But one of the things that we especially worry about, especially at where time is essence, is heart attacks and chest pain. Right. So chest pain, chest discomfort, chest pressure, shortness of breath, especially acute onset of shortness of breath, passing out. So losing consciousness. Again, losing consciousness could be dehydration, but it could be an arrhythmia. It could be a heart condition. Swelling in the legs. That could be a sign of heart failure. It could be a sign that you just have venous disease, but it could also be a sign of heart failure. So anything that is out of the ordinary, sudden symptoms, you have to get urgent or emergency care. Chronic symptoms, again, you may follow up with your GP who may have a history and be able to do some initial investigations before they then go ahead and either refer you or manage whatever symptoms it is. But in terms of heart attacks, strokes, those are acute conditions that require emergency treatment. So any loss of function, loss of speech, loss of strength, sudden loss of strength, those are all signs of strokes. And then the signs of heart attack, as I mentioned, sudden onset of crushing, chest pain. Women may present differently than men when it comes to heart attack symptoms. So if you're feeling something that is out of the ordinary, then you need to present. For some, it may be as simple as fatigue, you know. So again, you should, know your body, but also know when something feels different. Because time is muscle.
Yeah.
So we didn't get into the specific cardiovascular diseases, but the concern is, and a lot of people, again, think they're just having heartburn. If that artery gets clogged because of atherosclerosis, which is plaque, we talked about heart disease being a disease process where the vessels can get clogged up due to high blood pressure, diabetes, all those things. But that plaque that forms in your arteries can then rupture and cause a clot to form, and then you don't get blood flow. So blood flow ceases. If blood does not reach an organ, that organ is going to die. And that's what a heart attack is. So if they do not get you in within 90 minutes, we say 90 minutes to 6 hours, 90 minutes is the golden time to open up that artery. That muscle is going to die and it's not going to recover. And that's how people develop heart failure, because of one of the causes of heart failure, among other things, is when that muscle dies, the heart goes from pumping at normal 60 to 65% to pumping at 30 or even 20 or even 10, 15%, because that muscle is now gone. So certain conditions, same thing with a stroke. If you cannot open up that artery, then that muscle in the brain dies. If you get acute care and they can open up that artery within a period of time, you can get complete recovery and heal completely. So that's why we take chest pain very seriously.
What are 3 key takeaways that you would like our audience to know about our discussion today, from our discussion today?
Yeah, I think, I think you probably can figure that out from most of, the conversation. They go hand in hand. Know your numbers, have a primary care doctor, and get your physicals, see your doctor regularly. And I think one of the messages that we have to put out there is that heart disease is preventable. It is treatable. And we need to spread that good word and not spread myths about heart disease. It's treatable, it's preventable. Know your numbers and see your doctor regularly. So if anyone takes anything out of this, see your doctor, know what your numbers are doing, and if you have concerns about it, you need to have a discussion.
Yeah.
And then check in on your friends and neighbors and let them know that, you need to get checked out.
Yeah, and keep your numbers in your phone. That's what I do now. I have a note there, and I keep my numbers in there. I keep my medication, everything in there.
Right.
So if I go to the doctor or a new doctor and they ask me whatever, I just put up the note and I say, here.
Yeah, I'm a stickler.
Because
I'm a stickler for that. I tell patients I know that life is hectic. Everyone has a phone, all
phone.
right? They keep everything on their phone. And sometimes part of our job is managing the medications you're
Yeah.
on, knowing what is going on at home and the office. A lot of people have what we call white coat hypertension, where they're in a doctor's office and their blood pressure is through the roof.
Yeah,
So
that
one
happens
of
to
the
me.
things I advise patients is keep track of your blood pressure at home. It's not just about knowing it in your doctor's office. We didn't touch on that, but it's important that you keep a diary at home. If you do have high blood pressure, make sure it's well controlled, not just in the doctor's office. And know your medications, because God forbid you end up in the emergency department or you end up somewhere. You want to be able to tell them what you're on so that we don't cause a medical error by giving you something that interacts with something.
Yeah, and
So,
I learned also not just the name of the medication, but the concentration of the medication.
and the dose.
The doses,
It
yeah.
can't be that little white pill or that little pink
Yeah,
pill,
yeah.
because there's thousands of white pills, but people always tell you that pill. I'm like, please take pictures of your medications. You don't have to bring the bottles. If you bring the bottles, great. But take pictures. But there's also a lot of polypharmacy.
Right.
So you're seeing this doctor, you're seeing that doctor, and I may prescribe something, another doctor may prescribe something. So sometimes people are taking two of the same medication and then they don't feel well and they're blaming it on the medication, but it's also because they're not taking it correctly or they're mixing it up incorrectly. So all your doctors should know exactly what you're taking, even if it's not related to whatever condition you're treating them with. Just make sure they're aware that this is what I'm taking. It's important to some doctors based on how they're treating you. And for some doctors, they don't need that information. But you should always have that information readily handy.
So use your phone, put it to use.
There's so many apps that you can use to keep track of these things, to look at the trend in your blood pressure. It can alert you when it's running higher, when it's low. You can list all your medications. I mean,
so you don't have to try to remember all of this stuff. There's so many tools out there, and lots of them are free. The note that I use on my phone is free. It just put it in there, like you said. Sometimes I take a picture of it, and that has helped me so many times where I just hand it to them. And I remember one doctor said, "So thank you so much."
Yes, I love it when they come with that. I mean, we tend to tell our patients, especially our new patients, they're coming in.
So let's end on hope. What are some community-based solutions and things that we can do? This is a reality for us, but it is not the end of the world.
No, we all have to. Yeah, I mean, I think at the end of the day, we have to be each other's, what's the word? I don't want to say neighbor, but look out for each other. Keeper, right? There's the word. There are lots of ways to get the care you need. Churches, lots of health fairs people have, reaching out to people if you have a question or a problem. So outside of the doctor's offices I'm talking about, and of course there's organizations like the Heart and Stroke Foundation of Barbados that does advocacy. They do training, they do teaching, they do rehabilitation, and they try to spread the word. They do campaigns where they spread the word about heart disease and diabetes and obesity. So, there are lots of tools, not just Dr. Google. Dr. Google, you can get some information, but Dr. Google can also cause confusion and anxiety
and stress
and a lot of stress. So
sometimes you get overloaded.
Use your community, use the people at hand that can help. And then we already spoke about, just having a relationship with your doctor. The whole goal is to live a healthy heart life. And that is definitely doable, even if you're already diagnosed with heart disease.
Yeah, it is. It is possible. So how do people get a hold of you, Dr. Soyombo, if they would like to ask any questions, or if in Barbados or outside of Barbados?
We have an email address. Our office is healthyheartbarbados@gmail.com. So you can send us an email. In Barbados, you can call our office if you have questions, 417-3436, and they can definitely reach me that way. Yeah. And I'm also at the hospital, of course, through the hospital operator
as well. Yeah.
Yeah.
Okay, well, thank you very much. And we will put in the show notes some more information about Dr. Sayambo and the information about how to get in touch with her if you have any questions. So check that out as well. And thank you for your support again. And Dr. Sayambo, thank you for taking the time today. I really appreciate you.
Yeah, and thank you for doing this and shedding light on heart disease, especially in our men.
Thank you.
And encourage them to take better, or good, I shouldn't say better, care of themselves.
Thank you.